Hello and welcome to the Nurse Linda webinar for the month of June 2023. It's nice to be here. It seems like this has been such a hectic month that it just seems like it's gone by quickly, but there's so much has happened in the world of paralysis and in the world in general. Just so much is going on. I did want to have a few announcements before we start, and then we're going to delve into some of these questions. But first of all, I want to thank you to our people, our support people who are working with us today. You know, as the royals say over in Britain, you see the queen come and now the king, and it just looks like a swan swimming down the little river, and everything looks so peaceful and serene, and it looks so simple and easy. But what you don't see is his little feet paddling underneath, and that's what we have all these people that are supporting these webinars, you know, from the informational specialists to the people in charge. Julie, I'm talking about you. We have closed captioning and sign language interpreter will be joining us shortly, I'm sure. So there's a lot of things that go on to put these things on. So it's really nice that we have all that support for doing this. So big announcement. Oh, first of all, hello to Karen from Arizona, a colleague who I work with. She's a very proud supporter of the Reeve Foundation, and she does a lot of work with people in Arizona. So hello, Karen. It's nice to have you with us today. Big announcement I have for everybody is that back in, I think it was 2021, and the professional webinar, we had MJ McCully, who is an occupational therapist, on with Carrie Morgan. And they were talking about a project that they were doing about coaching, which is working with people to achieve goals, to learn new tasks, achieve goals, kind of a process of talking and interacting with people to help them learn something new. And it can be in communication, it can be in an action that they're doing. And so they have a study that's just opened. And I wanted to make sure that everybody knew about this because it's all about coaching. It's a study, so there is no fee involved. You just need to contact the people and say, I'd like to sign up for this, and you're in. It's 12 sessions. And they're all on video, so it doesn't matter where you live. You can enjoy this coaching session if you want. You do have to be spinal cord injured, and that can be from medical causes or from trauma. So, you know, all the people who have spinal cord injury from medical issues, you are by far more large in numbers than the group in trauma. So it can be either diagnosis, but you have to be 18 years old to participate. So I'm sure that there will be a pediatric study that will be following this at some point in time, but for right now you have to be 18 years old. It's through Jefferson Health, and the contact person is Rachel Kim at jefferson.edu, and we're going to put that up in the chat box there so you can contact that person. I do have a blog coming out next week all about this that has the information. So if you need more written information, there's a flyer that comes out and explains a little bit more about it. But as I say, it's all free. So anybody can, if you're 18 or above, spinal cord injury, you can participate, or a caregiver of a person who has a spinal cord injury can participate. And so even if you're not having any problems, or you just want to learn some new techniques for working with people, here's a great opportunity. I should think if you have an older adolescent child, or maybe a younger adult, like in their 20s, and maybe you're transitioning care to the adult world, or maybe you want them to take on more responsibility, or you want to know how to engage differently with somebody to get different actions and outcomes, this is an opportunity. I think a lot of people that I work with, oftentimes it's a spouse that's caring for someone, and maybe the spouse could maybe do a little bit more for themselves and be a little bit more responsible. And so this might be an opportunity for somebody in that type of situation that maybe they want to change something, and here's an opportunity to find how to do it in a non-confrontational sort of way and how to ease into it. And so you have time with the person on the video who helps you. You might be with your caregiver or just person with a spinal cord injury, learning how to deal with things, how to be maybe more aggressive, maybe how to be more accommodating, knowing how to ask for things that you really need. So anyway, it's a good opportunity for anybody. And as I say, it's all free. If you don't want to do this, but you're interested in coaching or other life skills, you can talk to your healthcare professional about getting connected with somebody one-on-one in your area. There would be a fee for that. It might be covered by your insurance. It depends on what your policy covers. So anyway, yes, the name is spelled correctly, Rachel Kim at jefferson.edu. So yes, that's just perfect. Now, another thing that's going on is this heat and humidity. And I just want to bring it up just as a little reminder. I know you all know it's hot out. You've got to keep yourself cool. You have to cool your car before you get into the car. You know how those hot cars just hold that heat inside there. It's so tremendously hot when you get inside the car. So cool your car before you get in it. If you're going to an activity, be sure and bring cool water to drink. Be sure and get some wet washcloths or a damp towel. Put it in the refrigerator so that it's nice and cool. Carry it in a little thermos or some kind of insulated container so it stays cool when you're out. Take rest breaks, find a place where it's air conditioned so you can go in and get cool. And those are all important things to remember about the heat. Now, remember, if you're on medical equipment, sometimes that doesn't have the air circulation around, so you can get really hot and your back can get really hot, or your bottom can get really hot where you're sitting. So be sure and do your position changes so that that area can cool off. That's not only important for your skin, but also for your temperature regulation. The other thing I want to remind you about in the heat is remember to look also at the humidity, because humidity, unlike heat will dissipate when you get cooler. Humidity collects and stays in your body. So the longer you're in a humid area, it's just going to collect and get worse. And it takes much, much longer to dissipate out. So be sure and check that humidity. And there's going to be some days now in this record-breaking heat that we're having all over, where maybe you just can't go out on that day. But remember that the humidity and the heat will eventually resolve and we'll all be out again. So, keep all those things in mind. There's a couple of neat things that are coming up. There's an abuse webinar tomorrow with Renee Lopez, who's a disability advocate. That's tomorrow at 3 p.m. Eastern. I plan to be there, so I hope that you will too. Now, you might think, well, I'm not abused, so I don't need to belong to that. But you might be on the lookout for other people. You might be find some ways that maybe people might be abusive that you really hadn't thought about before. So, it's just kind of a good idea to be up on some of those topics. I have a blog about that if you want to go back and, look up Nurse Linda blogs and look up abuse, because it's just an important situation. And, as I always say, it's not like, you meet somebody and they say something horrible to you, or they hit you across the face or something. Okay, I know I'm being abused when that happens, but abuse doesn't happen that way. It comes on very slowly and it comes on very subtly. Abusers usually just don't, well, there's some, but most of them usually just don't come up and start harassing somebody right away. Some people are, I'll say, ignorant to individuals who have differing abilities, and they might say something out of not really an abuse. It is an abuse, but it's not really intended as an abuse because they just don't know better. And so, differentiating that kind of thing. But as I say, abuse comes on very slowly, and oftentimes these abusers get you to think that it's you're the one who has the problem, not them. And so it's just a good idea to be aware of these kinds of things to help protect yourself. And then also on July 12th, we have the next professional webinar. And I wanted to announce that today also because we have Dr. Suzanne Groh, who is the head physiatrist at the National Rehab Hospital in DC. And we're going to be talking about all things bladder. Now, you know me, I could talk about bladder all day long. Bladder, bowels, and skin, not a problem. We could chat about it forever. So I'm really looking forward to that. And I think most of our listeners will be tuning in to hear about that too. So let's just cut right to the questions because we have gobs of questions. And then I think they're, appropriate for everybody to hear about. So the first question I'd like to talk about is, why is it so difficult to find help with? Okay, we had a little blurb there. Not sure where we left off. So the question is, why is it so difficult to find help with daily needs? This individual is a 35-year-old engineer and quadriplegic. He goes to work every day and he needs some help getting ready. So we do have, and it will appear in the chat box shortly. We do have a handout about finding help. But there's been a lot of changes in our country since the COVID. Everything has changed since the COVID. And so a lot of organizations that were helpful have dissolved in some funding of equipment and supplies. But finding people has also shrunk. If you go to a restaurant, it's common now that they don't have enough help, or they might close early, or, because there just aren't a lot of people out there working. The workforce has gone down. Now, I know that the job ratings have gone up, and I think, well, that's funny because in my area, it doesn't feel that way. But, reports are reports, and how they calculate that is on it has a certain metric to it. So it comes out differently, perhaps, than what you feel and see in your own community. But probably quadriplegic, not ventilatory, you're probably going to be responsible for your own care. And so you could hire someone, and you could put an ad out, you can talk around. Sometimes there's people who are retired, maybe a nurse or someone in your community that would be willing to take on it. There might be somebody who's looking for a job a couple hours a day. It could be that you might find a parent whose kids are in school and they're looking for some work a couple hours a day. You just never know when you're going to strike on the right person. You can ask different organizations. The Reeve Foundation has a place for finding help in your area. They have nannies and babysitters. They should have a online place where people could do care attending. You can call your local hospital, or if they have a rehabilitation center, ask for the social worker or case manager and see if they know anyone in your community that does that kind of work. A lot of times before people, the caseworkers, the case managers and the social workers will know people in the hospital, usually have a list of people that they have used that they can recommend that, this is a great person, or they'll know the background about it. So, this is pretty much word of mouth is pretty much the way that people kind of get this kind of information going. You can always place ads. Now, there is always this tradition of go to a nursing school and put up you have to ask permission if you can put up for a job for somebody, asking for help and specifying what's needed, because it will help them in their future career. And that is true. I have worked in schools of nursing, and physical therapy, occupational therapy in medical colleges, and it's very hard to find people through that way. Doesn't mean that it won't work out. You might even be able to find somebody like who's in high school that's interested in going into healthcare, that might be able to do some early morning work. So, come over, get you ready, and then go on to school. Sometimes they'll come after school too, so talk to the counselors in the high school and see it's a lot of legwork to try to find somebody, and then be very clear, know exactly what you want them to do. It's okay to hire somebody who doesn't know what to do if you know what to do and you can direct them. So like if you need them to do a bowel program, put that right up front, because some people are going to say, no, I'm not going to do that. I'll help you get dressed, but I'm not going to do that. Or some people are going to say, oh, I didn't know lifting was involved. So write out your list. This is exactly, do I want you to make my bed? Do I want you to give me a shower? Do I want you to make breakfast for me? Do I need shopping? Be very, very specific. I need to be turned this often. If you need your leg bag drained, emptied, be very specific about everything that you need. And that will help eliminate people who are like, oh yeah, I'll come over and help you. Oh, wait a minute. No, I'm not doing all these things. In the past, I haven't heard a lot about it recently, but different situations ebb and flow. But in the past, there's been a lot of discussion about, they hire somebody, they know they have to do the bowel program, and then they're like, yeah, I'm not going to do it that way. I want to do it this way, or I don't want to do it on time. I want to do it on this time. No, be very specific exactly about what you need. Also, I had a question that came in, and there's a link there where caregivers can be found. So that's another helpful in the chat box. Be sure and look there. Okay, so somebody wrote in, and they had a very interesting question about nerve transfers, particularly for hand function. And so nerve transfers it's not a new thing. It's going on right now. You can go places and get nerves transferred. You need to be evaluated. You need to qualify for this it's a surgical procedure. And what they do is, most people get it done for hand and arm function. What they'll do is they'll look at the nerves that are transmitting well. They may split a nerve in half and move half of that nerve and graft it onto another nerve that doesn't have the message communication for movement. They might split a nerve. They might move the entire nerve from one place to another. And then you usually have therapy before to help build up your muscles, so that when the nerve is moved, you're ready to move. Your muscles are ready to take on that information. You have the surgery, and then you're put into a great big soft cast, and you can't move your arm for several weeks. Now, sometimes it's less. It depends on what the surgery is. Sometimes it's more. It just depends on it specifically what they're doing, how many transfers they're doing, and they move a nerve from a place where it's working to a place where it's not working so well. And that because they have to have complete stillness, so in that arm, so that the nerve doesn't become detached. So, if you would happen to, flap your arm over, somebody's moving you. So they keep it protected, so that nerve graft is very delicate. It has to be protected for a long time. Then they'll remove that, and then they'll start therapy back again. But once your muscles have been developed, and then you stop for this period of time while your arm has to be immobile, your muscles will come back very quickly after that, because they've been used to that now. So that's usually the way the process works. Now, these are peripheral nerves, so they can be transferred. Peripheral nerves are nerves outside the brain and the spinal cord. So it'd be like a nerve from your shoulder might be moved to another location in your arm. And then, so you have to have therapy afterwards to reorganize your brain to learn, now this is how I move my hand. So a lot is done for pinch, a lot is done for grasp. You can get a lot of hand function by doing that. you do need to go to a nerve specialist, somebody who really knows how to do that type of surgery. And where you will find that person is in plastic surgery. Now, a lot of people think, what, plastic surgery? That's facelifts and stuff like that. But plastic surgery is a lot of reconstruction. So people who are in accidents that maybe have some kind of body disfigurement, that's where plastic surgery comes in. It's a lot of reconstruction. And so that's where you need a nerve specialist. So you won't be able to find one in, every single area where people live. You might have to go to a major academic medical center, a big medical center, even if it's not academic, but it's usually in larger places because it's such a specialized thing that you probably won't find a nerve specialist out in a rural community. But that's where you go for that kind of thing. And it is pretty much successful. Now, peripheral nerves have to regenerate. So once that nerve is implanted, say you just arbitrarily, you get a nerve transferred to here. Remember, it takes an inch per month for the nerve to regenerate. So if, say, you had something done in your elbow and you're going down to the tips of your fingers, that is more like 18 inches. So it's going to take about 1.5 years to see the full effects of that. So that can be a little, sometimes it's quicker, depends on what the nerve's activity is. That nerve is still able to, the nerve that's where the nerve is being transferred into, that particular nerve is still working. So you might get function quicker. It just depends, but you can count on peripheral nerves taking an inch per month to regenerate. So that's a long time. Now, sometimes they'll take nerves. It doesn't have to be just for hand function. Sometimes they'll do facial nerve transfers if you have something like Bell's palsy that did not recover. Most Bell's palsies do. Often for Bell's palsy, because the facial nerves are so delicate, it's such a unwieldy surgery, and sometimes it just never comes out right because of all the muscle structure, lots of tiny little muscles in there doing lots of different things. So sometimes what they'll do, if you don't recover from Bell's palsy, they'll put some Botox in the opposite side that is not affected by the Bell's palsy, so that you're at least in alignment, and then waiting for the Bell's palsy to recover. So the Botox slowly wears off. You might have to have several iterations of the injection, but hopefully the Bell's palsy will resolve, and then everything will start working back as it should have before. Sometimes they'll move a nerve in the abdomen for better bowel and bladder function. So there's a lot of that type of surgery that goes on, that comes in, that's usually done in the cauda equina, which are the nerves that come immediately out of the spinal cord. So they usually can graft those around to help with that. So there's lots of nerves grafting surgeries that are done, and they're very effective. Now, the next question would be, on to that question was, what about the Spinex and onward? So, when I was first asked this question about nerve grafting, I thought, that's an interesting question, because when you do these external stimulations, so Spinex and onward, and then there's another company called Anuvo that is doing these electrical stimulations. Now, we started out with surface electrodes on the skin. We call that surface electrodes. Implants, and everybody knows about the biking, and so that was kind of the way it started. And then they developed that more, and they still have in experimentation surgeries where they can go in and do some surgery in the spinal cord to help make some connections. And but that's really kind of dangerous, and so they're still working on that, trying to get that perfected still. But they found that if they took these electrodes and put them directly over the spinal cord instead of over the individual nerves in the body, the biking was done on peripheral nerves in the body. But now they found if they put these surface electrodes, so no surgery involved, and you put them on the spine where it's most needed. So some people have it up higher, so they get hand and arm function return. Some people have it lower and they get bowel, bladder, and leg return. So all this is coming to fruition. I mean, like right now. So Spinex and Onward products will be coming out in the new year. And we got delayed by the COVID, slowed everything down, but this is like real now. This is like, it's at the finish line. So it's coming. In fact, Spinex has a product for pediatric patients with spina bifida and will be used with children with spinal cord injury in the future. And that is called, I had a pamphlet right here for it, but I have the wrong pamphlet. I have the one about for the adults, but there's one that's coming out in January for children with spina bifida first, and then it'll continue moving through that population. Unusual to have the pediatric version to come out before the adult version, but hey, we'll take it however we get it. And we're going to have a webinar coming up on that either at the end of this year or at the beginning of next year. So if you go to the Spinex webpage, you can read all about that if you're interested in the pediatric one. So will you need nerve transfers after this surface electric stimulation goes to market? And by me, I mean coming out, I mean it's going to market. It'll be available all around the country, all around the world. Will you need the nerve transfers after that? Well, that depends on the uniqueness that's you. So it would depend on a lot of factors. It would depend on how well you respond to the spine stimulation. It would depend on maybe you've been injured for a long time and you need more oomph to get something else working. Maybe you get so much function with the spine stimulation, but you need a little more fine finger motion and maybe a nerve transfer would work. So it is all going to be based on individual needs. So that's the way that is going to go. So don't discount it. If you have the nerve transfer because you want it now, then, that's cool because, then it's done. So, that's just, it's just how you choose to, what you choose to decide, which is best for you. You might want to try the spine stimulation, see how that works out before moving ahead with the surgery, because the spine stimulation is not surgical. So you have that risk eliminated. So, not that surgery is bad. You can get function from surgery too. So those are the kind of things to think about with that. We all have to see how that's all going to work out. But there is a lot of success with these nerve stimulations on the spine. Is it like you were before you had your spinal cord injury? No, it is not, but it might be a lot more function than you have now. If you're happy with the function you have now and you don't want any of this stuff, that's fine too. It's not like we're pushing. We're just trying to get information out to you so you can make your own decision. Maybe you want to wait a year or two and see how the spine stimulation's going in a year or two. That's entirely up to you. Do what makes you feel comfortable. Do what's right for you. Okay. So there's a person that wrote in about nerve pain. And yes, he's having trouble. I don't know that it seems like he's doing maybe some massaging for the nerve pain. Nerve pain is very difficult to treat, but there are medications for it if you're interested in taking medications. So yes, nerve pain can get better and nerve pain can resolve. A lot of people don't know that, but that is true. It doesn't resolve for everyone. Why it resolves for some and not for others is unknown, but we're trying to figure it out, because if we knew, we'd have everybody doing it so we get rid of this nerve pain. So nerve pain can't be treated with opioids. A lot of people were, we had that big opioid controversy and some people still are taking opioids for it. So you want to try to get off that because it is not affecting your nerve pain. It's affecting your brain signals messaging of the pain, but it's also dulling your senses. So you want to try to get off of that. Now, you can take low dose antidepressants, low dose anti-epileptics. And what they found was people who have depression or people who have seizures don't have a lot of nerve pain because they're on these medications. Now, when you're taking those medications for those particular issues, such as seizures or depression, you could get them at a much higher dose. But for people who don't have seizures or depression, they give little bitty doses. So that helps control the nerve pain. There are 2 medications that were specifically developed for pain control. And those are gabapentin and pregabalin, Neurontin, and then later developed was Lyrica. So those are the 2 medications. Now, those you have to titrate on. And then if you decide you don't want to take those anymore, you have to slowly titrate off of them, or the pain becomes much worse. And it becomes very difficult to treat if you suddenly stop cold turkey. And I tell this to people all the time: when you get on these medications, they're fine to take, but don't stop them cold turkey. People leave and they go out and, oh, I'm going to tough it out. I did it. They come back. I should have listened to you. What a mistake. So be sure and follow directions specifically for these. Now, there is a toolkit for pain management. You can see it there in the chat box, so you can get more information. But medication is really one of the ways to go. Now, some people do acupuncture, acupressure. Some people do biofeedback. Some people do a combination of all of these things. Some people have an implant put in their abdomen with a little tube that goes around to the spinal cord area. And medication can be put in there to bathe the spinal cord for spasticity, but also for nerve pain. So that's a more extreme. There's a very extreme surgery, which we try not to recommend to people because, you know, our goal is to make these nerves work again. So we don't want you to cut nerves. That's usually, most people usually do find with the medication that it does turn out to work fine. Some people are anti-medication. Now, sometimes you have to go up in the dosage of your medication because your body becomes accustomed to it. Some people don't like the side effects when they first go on the Neurontin and Lyrica, but if you can tough it out for 8 days, side effects usually go away. So it can be kind of tricky. It's big medicine. So you do want to think about that. For some reason, some people will say, you know, this isn't really working anymore. I want to try a different medication. You have to completely titrate off that first medication before you can start a new medication. You can't be on 2 at once. That conflicts things and it doesn't work. So you have to be completely off. Some people will be on the pain medication for a year, 5 years, 10 years, 20 years. For some odd reason, they have to titrate off and go on to a different medication. And when they titrate off, they're like, but my pain is gone. And that's why I say it does resolve. We don't know why it resolves. We don't know why it works that way for some people. We don't know how long it takes, but it works that way for some people. So it can go away. So that's the good news, but you almost have to treat that. But there are alternative treatments. If you don't want medication, you could try some of those first and see how that works out, like the biofeedback and the acupuncture and those kinds of things. So all of that is in that toolkit, which is very helpful. Here's somebody who wants to know about people with multiple disabilities. So they have a person who's 96. She's got the macular degeneration, which has affected her vision significantly. She's paralyzed from the waist down and she has dementia. And so they need some help. And I think help, like hope kind of help. And, you know, getting the right services and finding something that this person can do is really a big helpful, something that occupies them. If they enjoy reading and they can listen to books on tape, or if they if they can do some activity that's something that would help other people. So sometimes if it's a woman, so sometimes, and she's 96, so sometimes, look at what her hobbies were before and think how maybe they could be done differently. Find a purpose for her. So if, she can fold towels and washcloths and become a member of that household activities so that she feels like she's contributing. If there's some kind of cooking activity that she can do, as far as, like maybe putting out the plates, or washing the fruit when you bring it home from the grocery store, something that she has responsibility for, is always very helpful for people. I don't know about the significance of the dementia, but sometimes, people with dementia, they like to have routine activities. Setting up a very clear routine so that they know what's happening, what's going to happen next, is very helpful. So, and sometimes too, I know some people are religious and some people are not. And so but I'm just going to say this: at 96 years old, she maybe grew up in a time when people were very religious. And so if you belong to a church and there's a prayer list, helping her with the prayer list and praying for individual people is very satisfying to people who have a religion in their life. Now, if that's not your thing, you might find something else that might be a program that they like to listen to, or something that you can maybe engage in some way. Company, if company does not bother her, then maybe you can arrange visits, or there's all kinds of different things to kind of help break up the monotony of the day and see what kind of things are going on. Here's one that is, this is a good one. Is lamb's wool or sheepskin good in helping preventing pressure sores? Yes. You need to have more than just a lamb or sheepskin. You need pressure dispersing equipment, but lamb and sheepskin, laying on that, because of the nature of the way that fur is developed, it can have airflow that goes through there. So if you're on a piece of medical equipment, sometimes that doesn't really breathe very easily. So having that lamb and sheepskin under there is kind of can make a little circulation underneath side of the body. It also helps while you're turning, so you don't, shear the skin. So it is a piece of the puzzle. It's not the only piece of the puzzle. No matter what you do, you still have to do those pressure releases. That is just all there is on that one. This question is a bugaboo in my own heart and soul. So, my concern is that the doctor's office state they're handicapped accessible, but only have wider doors. Shouldn't they have tables that go up and down to accommodate those who can't stand? Yes. It would be nice if every single physician's office had that. Most rehabilitation doctors do have that because that is their clientele. It would be nice for people who go to other doctors. Maybe you're going to the urologist and you need a urodynamics study, but you can't get up on the table because it doesn't go up and down and they're up pretty high. Even people who are elderly, they can't get up and down on some of those tables. People have back pain. It might be. There are all sorts of reasons to have that, but they are more expensive. So, it's always the cost benefit. And if people don't really come there that aren't walking, in fact, all clinic rooms, you very rarely find a clinic room that is easy to navigate with a wheelchair, especially a recliner or one of the bigger types of wheelchairs. It's just almost impossible. I take my own mother to the doctor. She's only 95, she's not 96, but she's looking forward to it. But I take her to the doctor and we use a wheelchair just because it's such a long distance for her to walk from point A to point B to get into the doctor's office. So she could walk, but we just do the wheelchair. It's so much more convenient, doesn't wear her out so much. And I'm always struggling. I've been taking wheelchairs in and out of doctors' offices for 45 years now. And let me tell you, it's a challenge for me. I'm always bumping into something and I just like, why aren't these doors wider? Because they're only built for people who walk. And that is just a tragedy. I don't see why. I don't understand it myself. We need to get a consumer advocate group on this and get this straightened out. We do have a question in the chat box. And what's the latest on surgical cure to SCI? Well, there's a lot of things that are going on with that. Like I was saying about doing some of the implants with electrodes. Of course, the big objective is to be able to reattach those nerves in the spinal cord. You cannot do that with nerves like peripheral nerves. You can't do it in the brain and spinal cord like you can do in the all the other nerves outside the body. So, but they're working on it. People are trying to figure it out. There's a lot of different things that they've experimented. They have these things called glass tubes. They're not glass. They're not like a glass that you drink out of, but they're little tiny tubes and they go around from one end of the nerve to the other end of the nerve. They do it a lot in peripheral nerves that get severed in some way. And it creates an environment in there that causes the nerve to regenerate. And so you put one end of a nerve in this end of the glass tube and the other end in this end, and the nerves start to generate. The glass tube makes them grow in the right direction so that they meet up. Now, the reason why they're called glass tubes is because after a while, these tubes just dissolve. So they're like glass in that they just disintegrate. I don't know. It's kind of a weird name for it. But so anyway, that might be a possibility. They're looking into that in the spinal canal. They're also looking into the stem cells. And that is a surgical procedure because the stem cells have to be injected into the spinal cord, and they've made tremendous progress on this in the last 20 years. I mean, just huge. 20 years ago, stem cells was the and what seemed to be the answer. And it probably still will be a part of the answer, but there's still some issues with trying to get it in there without causing more damage. Once they get it in there, would it grow? And they created a scaffolding so it can grow, but it doesn't grow fast enough. So now they're looking at what kind, so it seems like for every step forward, there are 10 more questions. And that's the way research is. So, you have to be able to accept that when you're a researcher, that it will go on forever and ever. But things do come to fruition, which we are seeing with a lot of the e-stems. So that's why that's so big now, because we've mastered it now. So that's good. And that will be mastered as well. So, more to come on that. So there's a lot of chemicals, the nervous system works on electrical charges, and there are different chemicals that cause these electrical charges. And there's all kinds of research that's going on with that. And so we're going to be hearing, I think, more about that in the upcoming new year. There's a question about alternating seat cushions, specific recommendations, usefulness, just checking that I have it. And I know I answered a question about this at some point in time. Air alternating seat cushions are great because it shifts your weight a little bit. Still have to do the pressure releases, but there are many different varieties. So usually you don't get these higher level cushions until you've had a pressure injury, which is kind of backward thinking, but that's usually the way these more expensive items go. You can advocate. There might be something in your health history that might be something like if you have spasms that cause your seating bones to rub up against your cushion, or there are all different kinds. If you're emaciated, people who are extremely thin and people who are extremely heavy both have issues with pressure injury more than people who have good muscles in their body. Fat people always say, "Oh, I got plenty of cushion back there because I got a lot of fat." Well, that includes a lot of us. But fat does not disperse over the bones. It makes it harder, applies more pressure to the bones. And of course, if you don't have that muscle cushion and you're very thin, then your muscles are not protecting your bones. So building up the muscles that go over those bones is really important. But the alternating pressure seat cushions, those are lovely. They're very effective. Really, the effectiveness depends on what a person's needs are. So if you don't really need that alternating pressure seat cushion, it's probably not going to help you all in all that much. It might give you some peace of mind or some confidence, but it is one better than another? Well, there's kind of levels. There's the gel type cushions, medical foam cushions, then the gel cushions, not foam from the craft store that doesn't disperse fresh pressure, that creates more pressure. Pillows are completely outlawed. Pillows are useless. Don't use those at all. They add more pressure. And then you go up to more the air filled, like the Rojo brand. There are other brands as well. Rojo just pops into my mind. And then you get into these pressurized. So they usually have 4 sections in them. And so when this cell is filled, this one is lower. And when this one comes up, that one lowers. And when that one comes up, this one lowers. So it moves the pressure, how you're seating around. And they are very effective, but you still have to do your push-ups no matter what. There's no pressure cushion that eliminates pressure from your body. And that's just the way it is. Here is a person that went into a specialty hospital for 3 weeks of IV therapy and wound care after an ischial abscess. So pretty significant. She didn't feel like she got good care there, was having dysreflexia. She says they didn't change their catheter and refused a bowel program. So she laid in diarrhea, exposing that to the wound. So when you get in these situations and you feel like nobody's paying attention to you in the healthcare setting, it's important that you talk immediately to the nurse manager and explain what your needs are. And if that you don't get any results and change from that, you go to the vice president of nursing, because these are nursing care issues. And if you don't get any results from that, you need to call the state and report that you're not being cared for properly. Hopefully the problem would be resolved at the lowest level with the manager, and things would be, a care plan should be set up for you. And that, because these are not unusual requests. There should be physician orders for addressing these issues. Bowel programs have to be done on time. You can get some of the information from the Christopher Reeve Paralysis Foundation about bowel programs, about bladder programs, about AD, and have that in your room. It's all free. Hand it out to people. Give it to that nurse manager. It shouldn't be up to you to teach people in healthcare how to take care of yourself. But if a lot of people in healthcare have never taken care of a person with spinal cord injury, so they don't have any clue really. They maybe had a 15-minute lecture on AD in medical school or in nursing school. So, that's flown out of their mind a long time ago. So you need to find somebody who's on, who you can help. There's usually a hospital ombudsman or a legal representation. There's an ethics committee. Those the ethics committees move more slowly, but this should not happen to you, and it should not happen to anybody else. So be sure and work up the chain of command, because you don't want to embarrass the people by going right to the vice president of nursing, and then they get called on the carpet, and then it kind of sets up an antagonistic relationship. Be cool, calm. I'm not getting the help I need, and these are the things that I need. So those are the things to do. Now, it sounds like you're out of this situation, so that's good and back into things, but that's a very dangerous situation. And you do want to report that what happened. So if, report it to the state so that they know. They come in and they supervise what's going on. They can review your case and, correct it for you the next time or for the next person who comes into that place with this kind of issues. Any grants for exercise equipment for people with quad conditions? We get this a lot. We kind of opened up with this question, and we get this a lot about exercise equipment, people wanting equipment. Check with your insurance company. Ask your physician to write an order for the equipment. Then the equipment probably will be denied. There's an appeals process. Keep appealing and appealing and appealing. There was a man on TV several years ago where I live, and he put himself on the news because he spent 5 years getting an exercise bike and what he went through with the insurance company. And I thought to myself, I wish I had a tape recording of this man, because it was on and then it was over so quickly. But I wish I knew who he was to this day, because he never let up and he got what he needed, but it took him 5 years. And that was just an impossibility. People lose interest and, they're like, well, I guess my insurance denied it. I guess I'm never going to get it. Keep working there. The cost of bikes have gone down. Exercise bikes have gone down tremendously. And so things are loosening up a little bit in that venue. You can also ask. Most insurance and Medicaids have 2 weeks of mobility training per year in your contract. If you have that in your insurance contract, use those 2 weeks to go in and learn to use a bike. That's mobility training. Learn to use a standing frame. Learn to use this kind of equipment. And when you've successfully mastered it, then it's easier for your physician to write to the insurance and say, look, they did this thing and it's really doing wonders. It's worked well for them. So that's help. Go to your community organizations, the Lions Club, the Kiwanis, Knights of Columbus, any kind of organization that you can think of in your community. And they might say, oh, we don't really supply equipment to individuals like that. Just wait a while and call back and talk to somebody else until you hit the right person who's really interested. Maybe they'll say, well, our organization doesn't do that, but I know this guy who will help you. So, you just have to work this stuff down. It's really a shame, but this is the way that it goes. Here's a question about those air cushions, and this is a person. They're looking for recommendations. Really, it depends on what your insurance will pay for. So a lot of times you can get a recommendation from your healthcare professional. Your therapist will recommend something, but your insurance company has a contract with another company. And it's just as good a product, but it's a different brand and it doesn't quite look like the one you're accustomed to, but that's okay. So they're all good products. So here's a question, which is the best bandage for covering minor scrapes, cuts, etc., not for major wound care. So this person has all kinds of dressings, hydrocolloid, all different kinds of adhesive dressings, even Band-Aids. So if you get a little cut on your finger, a Band-Aid works just fine. If it's an area where you don't have sensation, you do want to be a little bit more careful, because a Band-Aid has that little bit of cotton gauze inside the Band-Aid that you put over the wound. And if that is on a place that's rubbing, that can be quite irritating. And I know myself, like if you've ever gotten a blister on the back of your heel, from your shoe, and so you put a Band-Aid there because it's got that little bit of cushion there, and you put that over your Band-Aid, but that Band-Aid rubs on that tender skin of that blister and makes it worse. So anytime you can get any kind of Dressing that does not rub if you have a cut or an injury below your level of sensation. Then consider some of these alternative silicone dressings or anything to keep, if the wound is open, you need to keep it covered. You want air to get to it, so you don't want to seal it off. But you want to keep it covered. You want to change that dressing at least once a day. Twice a day is probably better. Wash the wound with soap and water so that until that heals up. So just like a regular old cut, I bumped my leg into my shin into the side of my wheelchair and I got a little cut there. You can put just a regular Band-Aid on that. But consider the wound if it's an area of poor circulation, or if it's an area where you don't have sensation. So you want to take something that's easy to put on and easy to put off and is very soft over that wound in case that there's some rubbing there. Here's an interesting article about a question about somebody who has a brain injury, and he did great at Kessler. He's turning 30, but he went very contracted. Now, they think that it was from the care at the hospital. Sometimes with brain injury and spinal cord injury, contractions happen irregardless of what happens. They can be doing range of motion, they're getting therapy, and still a person will become contracted. The reason for this is you have muscles that push away from your body, and you have muscles that pull towards your body. And when a person gets contracted, you'll see that their appendage is pulled towards their body and that the muscle is contracted. It can't be ranged out. It can't be stretched out. Maybe the fingers can't be uncoiled because there's contraction there. There are treatments to be able to loosen that up. Botox. There are surgeries that have to be done for extreme contractions. There are even devices that over time, they'll put on a splint that's just like over a top of an arm or a leg. And there's a dial on the side, and very slowly over weeks, they will stretch out that muscle. And so that takes a lot of time. Some people don't want that to do that much time, but some Botox sometimes will help that contracted muscle loosen up. And then you have to have therapy. But was it really the fault of the people in the hospital? Maybe not, because sometimes the part where that brain is damaged, it's saying, contract that muscle, contract that muscle, contract that muscle. And that part of the brain's been damaged, so that signal cannot be switched off. And so doing all the preventions, sometimes just, they don't do it. That's one of the reasons why we say, if you feel like you're getting a contracture, go to your healthcare professional and start getting treatment right away. Don't feel like you have to go and say, oh, I didn't do my exercise quite right, and I got this, so I'm going to get yelled at. No, it's not your fault. It's usually not your fault. So sometimes people do their exercises and they still get contractures. So that, look into different alternatives for stretching that out. Don't try to do it yourself, because you can try to force that and then that will break a little bone in there or will rip the muscle. So be sure and go to a therapist that deals with those muscle contractions. Any advice on speeding up wound healing while maintaining a functional day? Well, the number one thing to heal a wound is to stay off of it. There are some, there's an item called the wound vac, which is, it's actually a little vacuum, and you put some occlusion, it's like a great big huge piece of saran wrap, but it's sticky on the one side. And then it looks like, one of those old fashioned hair dryers with a little nozzle that fits into this. So it's all sealed, the wound is all sealed up, and that will remove debris and any sediment or anything that's going on. It keeps that wound clean, and you don't change it every day. You don't change it for every 3 days. And then that helps a lot. And some people think that heals a wound much faster. There are some different ointments and treatments that you can put on wounds that people think heal the wound fast. You just want to be sure that you heal the wound from the deepest point out to the skin. Because if the skin closes over the top of the wound, then that can create an abscess in there and a cyst. So just be sure you get that, but staying off of it is the big thing. I know it's horrible, but if the wound is really bad, you could try a wound vac, or, be sure and talk to a wound specialist. Most hospitals have wound specialists. It's a whole department kind of thing. And so be sure and talk to somebody about a specialist about healing that wound to help you get that healed up quicker rather than later. Here's somebody who, after 5 years, they're getting crystals and sediment in their urine and it's blocking their pubic catheter. Now they have to change that weekly. How do I reduce or eliminate the crystals? Now, first thing is to drink more water. Water is the best. Another thing is that sometimes people get those because they have a urinary tract infection. So check and make sure that you might not have any sensation or feeling of that. So check and make sure that's not going on. Another thing that people sometimes say is it's demineralization of the bones. So if you have not had a bone density test, be sure and check in that. That's kind of an out there kind of thing, but it's out there. So be sure and check about bone density. Have some lab work done to see if there's any metabolic reasons why you're producing more of these. And then is it safe to change it every week? He has to change it weekly. Check with your healthcare professional to see if you can irrigate it. If it's clogged, you have to change it. I mean, that's just all there is to it. But maybe if it's just a little bit clogged, you can kind of reduce that sediment within the catheter. So check and see about that. You might want to check with a urologist if you don't have a urologist to see why those sediments are forming for you in particular. Here we have another person that wants to lose 10 to 15 pounds. We had a wonderful webinar with Dr. David Gator. Oh, what a lovely man. And he studies metabolism, and we talked about all different kinds of diet strategies and all different kinds of things. Counting calories was his answer. So, what goes in, you've got to burn up that much energy. So if you're, if you have paralysis, you might not be burning as much energy, and therefore you don't need as many calories as a person who doesn't have paralysis. So be sure and talk with your healthcare professional. He can get a nutritional consult for you. Don't just start limiting your intake, because you might not be getting the nutrients that you need to keep your muscles healthy so you don't get pressure injury. So get a nutritional consult and find out what is the right thing for you to do to lose those 10 or 15 pounds. So that's probably the best answer. And as Dr. Gator says, counting calories right now is the answer, but you don't know how much calories you need if you're not moving or not fully moving. So you need to have that assessment done. So it's a process like everything else. So this has been a wonderful session. I like talking to you. I like answering your questions. Please feel free to write in to the nurse, Linda, at the Christopher Reeve Paralysis Foundation website. There's a button there that you can ask me a question directly. I've gotten to all the questions today, so yay. It's a red letter day, and be sure and tune in tomorrow on that Recognizing Abuse seminar. You can check and see how to log on there if you haven't gotten the email already. And then on July 12th at 2 p.m. Central, All Things Bladder with Dr. Suzanne Grohl. Looking forward to it. Hope to see you there. Thanks for joining us today.